Well, hi, everybody, and welcome to our Excite Ed. Listen, I'm here with my friend Tanner Ferguson. My name's Matt Jensen, and we're here on behalf of RX Site, where we're talking about the usage of the LAL and the LAL Plus at the point of care in real life at practices. And like I mentioned, I'm here with Tanner Ferguson, MD, who works out of Sioux City, Iowa, and Sioux Falls, South Dakota, just 90 miles down the road. He and I worked together at Vance Thompson Vision for a time. And Tanner, welcome to this session. I'm excited you're here.
Thanks, Matt. Excited to be here and excited to be on here with you.
Well, one of the things that we do with this session, our Excite Ed, is we really try to get down to brass tacks of how each individual provider or each practice, how they use the technology in their centers. And you have a unique role because within the two models of the two practices right down the road from one another, you operate a little bit differently with how the choreography works. Maybe you can tell us a little bit about the unique position that you're in.
Sure. So I'll give a little background here. So as you mentioned, I work in two locations, Sioux Falls, South Dakota, which is where also I did my fellowship. And in Sioux Falls at our location, I have an optometrist who works alongside me, who's there 5 days a week, and her name's Dr. Kristen Moore. And then I also work out of our Sioux City location, which is actually in Nebraska. I'll remind you, Matt. People in the tri-state area, they like to own what they have. It's actually on the Nebraska side. And I'm there Monday, Tuesday, and some Wednesdays, but I do not have an optometrist working alongside me there. And so we added when I first started about almost 2 years ago now, we did not have an LDD at the Sioux City location, but we added that about 7 months ago. And so my first about 16 months into practice, my experience with the LAL was I did the surgery and the optometrist performed all of the adjustments. And then since 7 months ago, that model has kind of shifted to where when I'm doing surgery in Sioux Falls, Dr. Moore still does the majority of the adjustments, but in Sioux City, I do my own adjustments.
So, what are some of the pearls that you found now that you're kind of doing kind of a half and half program? You're very hands on in one environment, and in the other environment, not you're very hands on the surgical part, but have a partner working on the light adjustments.
I think I don't really see there's any big difference between the two in terms of the outcomes. And I have a lot of, um, confidence in both models. And I think that kind of stems from my training environment where, I did my fellowship in Sioux Falls and where the optometrists were the primary providers of the light treatments for all of the surgeons in the group. And that was my baseline experience and it worked exceptionally well. And so when I started doing my own adjustments, it wasn't necessarily, I didn't question whether an OD could deliver out great outcomes. It was whether I could match the level of quality and consistency I was already seeing in the collaborative care model. And I think that kind of speaks volumes about how effective and this partnership can be,
Give
or
us a
this
sense of how,
partnership model.
yeah, give us a sense of how you collaborate with the OD in Sioux Falls with Dr. Moore. Do you meet regularly on cases? How does the communication go back and forth about patient expectations?
Yeah, and I think we keep a very open communication channel, and that's with patient trends, what we're seeing with the performance of the lens, maybe adjusting our targets out of the gate. Um, and so I'll kind of get to this later, but when I first started, there's instances where Dr. Moore signs up the patient for surgery, and I come in and kind of confirm the plan for the light adjustable lens. But there's also instances where I sign up the patient, and in those instances, I'll document like an anticipated light adjustment plan based on the visual goals of the patient. And then if I know there's a patient that's a little bit unique or had unique visual goals, then I'll kind of communicate on top of what's in the chart. But I think the takeaway here is communication.
Yeah, well, I like that, and that will be the case if you ever add, an OD to your Sioux City location as well. And I'll see your comment about Nebraska and up you one. It's South Sioux City.
That's
When
right.
we're talking Nebraska, so touche. We both get 1 point. The From a clinical standpoint, what are you seeing in terms of outcomes and patient satisfaction, if it any different between, who's doing that light adjustment?
Hmm. Clinically, I've seen no difference between the two models. And I think the main difference I've observed is more personal. And I think I get to see, as the person doing the adjustments, I get to see that immediate wow moment when somebody experiences a dramatic improvement after an adjustment. And I think that's been incredibly rewarding. And it's kind of changed maybe my perception of the technology, and maybe deepened my appreciation for the technology. I used to think that the happiest possible patient was a trifocal patient who saw amazing at distance, intermediate, and near. But I found that many LAL patients, especially those with a successful outcome based on their goals, are just as happy, if not more, because of the customization and quality of vision they can achieve.
Yeah, and I'd like to talk to you about that. We've had this discussion actually over coffee a couple months ago. Um, Share with us the talk track you use when you're talking about the light adjustable lens in the practice, because you really invite the patient in on the journey of several visits. How do you do that?
So when I talk to a patient about their options, I first kind of emphasize that, choosing a lens at the time of surgery is really choosing how they want to use their eyes going forward. And kind of talk through the process of, your natural lens aging, how it kind of goes from a clear, um, flexible lens into, kind of stiffens as you get older and then develops into a cataract. And I talk through, we remove that cataract, replace it with a new lens that should last you the rest of your life. And so that's why it's a choice that dictates how you want to use your eyes going forward. And I kind of initially position it, I mentioned there's different lens options available to you at the time of surgery. Choosing a lens kind of comes down to how well you'd like to see without glasses. And if they have said to me something in the conversation that clues me into they would be a great candidate for light adjustable lens, I'll usually say something like, based on your visual goals, I think you would be a great candidate for the light adjustable lens. And then kind of talk through the advantages of the technology, talk through the ability to customize their vision through a series of adjustments. And then once they're happy with their outcome, lock it in and it should not change after that.
So, Dr. Ferguson, you mentioned that when you're talking to the patient, you said once you understand some of their visual goals, what are some of those cues, or how will you know that they might be a good candidate uh, for the light adjustable lens versus maybe some other options?
Sure. If a patient comes in and they have a history of success with contact lens wear, particularly if they have a difference between the two eyes, that patient to me sets up really well for the light adjustable lens. And I think the reason is that our natural lens, even when a cataract develops, has some element of depth of focus that, what we'll often do is we'll target the same as what they have in their contact lens. But that may not be what they need after surgery because we lose that little bit of depth of focus that is present in their natural lens. And having the adjustability factor of the light adjustable lens after surgery, after they heal, is such an advantage for those patients. And those patients are also very predictable to adjust after surgery because they have a healthy, untouched cornea, and they tend to be very happy because we can oftentimes get them uh, less of a difference between the two eyes than what they're accustomed to, and really customize their vision to what their visual goals are.
That's an excellent response, and I think that in particular will be helpful to other listeners to this session regarding what to look for. So that's great. I want to come back to the unique model that you have, seeing a surgeon versus an optometrist for the light treatments, and if you would, because you touched on this, but you've got a lot of confidence in your optometrists doing the light treatments. And I've heard your partners talk about that similarly because they're some of the best uh, people who do refractions on planet Earth. What gives you that kind of confidence in them, like you, doing the light adjustments?
Well, I think we didn't reinvent the wheel when it comes to training or oversight. I think we as surgeons and optometrists all went through the same training provided by RxSight. And I think that consistency is key and ensures that whether it's me or the optometrist doing the treatment, the foundational understanding is the same for all of us. And I think, like anything in medicine with technology, experience adds nuance. but I think the core technical components of light treatments are pretty straightforward. And I think what makes a difference with a collaborative care model is really the communication and teamwork. Um, but I think the most important aspect of a light treatment comes down to a precision refraction. Just like LASIK, where if a patient didn't like what they saw through the phoropter, we wouldn't turn around and plug that refraction into the laser to do LASIK. Same thing with a light treatment. If the patient doesn't like what they see through the phoropter, we're not going to plug that into the light treatment. I mean, so I kind of approach it the same way. And I think if you think about who's, should be best equipped to perform a refraction or precision refraction, it's often an optometrist who has a ton of experience with that.
Well, not only that, but they're blessed with something that because they've been doing it for so long. I often heard that some of the most powerful things you need to have in refractive surgery are are these.
Yeah, that's right.
Listen to your patient, right?
That's right.
And their preference. Really, really
And
important.
and one thing I'll add on that when it comes down to a refraction is not only chasing like a line of vision,
Mm.
but chasing quality of vision. So is that vision, you're reading the 20/20 line, but is that line crisp? Do you like what you see out of the phoropter? And I think that additional aspect of chasing image quality, I think is a helpful refractive endpoint.
Yeah, chasing image quality. That's a really good way to say it. Let's talk as if I'm the patient and I'm getting my first light treatment, and you're encouraging me to go out, for the next couple of weeks or however long. Um, what does that conversation look like? What are you telling me to do with my vision?
And the first thing I'll do is I'll say, after your treatment today, it's normal if things are blurry for a while. We just dilated your eyes, performed a light treatment. But starting tomorrow, use your eyes. Look, see how your vision's performing at distance, intermediate, and near, and use your eyes in the way you typically do to understand if where you're at right now is if you like it. If you feel like after a couple of weeks things need to change, well, we have that. We continue to adjust things up to two more times before we lock it in. But live your life, use your eyes, try and understand if where you're currently at, are you happy, and kind of go from there.
Yeah, I like that. And I've I've heard you say things before like I want you to notice your vision, right? Notice yourself looking out in distance, notice yourself when you're playing golf. See how how you're feeling it as you're looking at things off on the horizon versus your golf short game. And so I think those kinds of commentaries are helpful for patients to know what to anticipate and also to be given an assignment during those couple of
Mhm.
weeks. Um, Now, not every patient is happy, right? And so, whether it's the optometrist doing the light treatment or it's you doing the light treatment, how do you flag concerns and circle back with them?
Yeah, I think it's like I said before, it comes down to clear communication and keeping an open communication channel between myself and the optometrist that I work with. And so if a patient ever has questions and I haven't been seeing that patient for adjustments, or if they're not quite as happy as we'd expect, then we always offer the opportunity for them to come back and see me on a day when I'm in the clinic. And oftentimes it's just, hearing the same thing they've already heard from the optometrist I work with, that same messaging. And I think that shared or that continuity really just provides reassurance that what they're experiencing is normal. They're doing better than they probably appreciate. And I think that continuity kind of reinforces our shared commitment.
Yeah, that's good. That's good. And I think, one of the things that I've heard you mention is that this amongst your premium IOL offerings tends to be, the largest subset because of your confidence in it. Are you able to talk a little bit about why you're so confident in the LAL platform?
Yeah, I think to me, the light adjustable lens has the broadest applicability to patients. I think some of our advanced technology IOLs, while great, have a narrower, pool of candidates for the technology, maybe based on the concomitant pathology, other things going on, their visual goals, or maybe aversion to, compromised visual quality. And I think where the LAL really shines is quality of vision, customization, and then, the ability to overcome limitations with the IOL power calculations. And I think those three factors have really played a role into deepening my confidence with the technology, and has kind of shaped how I position the lens when I recommend it to patients.
Well, that comes back to the comment you made earlier that I think is going to be my take home message from this conversation, which is don't chase a number, chase quality of vision, right? And it's unique because patients get to walk around with this technology for a time, so they'll know whether or not it's high quality vision for themselves or needs a little tweak. So I
That's
think
right.
that's
And I think that the phrase we like to say is you get a chance to test drive your vision in
mm.
between the adjustment process. And that's what sets us apart from a different lens.
Dr. Ferguson, one of the things that I hear when I go to national meetings and things like that, people will come up to me quietly and they'll say, I like the technology, but boy, it just takes so long. What do you say to them?
I kind of bring it back to the importance of this decision for choosing a lens. And even if a patient kind of pushes back on the additional visits, and I'm still very transparent that this lens, incorporates additional visits versus another lens, but this is impacting how you use your eyes for the rest of your life. So if that means 3 to 4 extra visits, but a chance to impact how you see for the next 15 to 25 years, what's 3 to 4 more visits for a patient? And that's
Hmm.
kind of how I position to both patients and then people who kind of push back on the additional visits.
And do you talk with them when you're talking to people who are maybe naysayers? Do you talk about the importance of securing patient buy-in along the way? That's the natural output of this is patients, they're self-selecting themselves into happiness because of their directing the adjustments.
Right. I kind of um, I kind of use the similar wording what I just said about, this is ultimately going to impact how things are going to be for you going forward. And it's important, or it's okay to be patient. There's no need to rush through this process because of that, impact of, vision for the rest of your life.
Yeah, I really like the vision for the rest of your life conversation. You've mentioned that a few times. Um, this collaborative approach between you and optometry versus the approach that you have where you don't have an optometrist working with you directly on the light adjustments, um, is one model more efficient than the other?
Well, I think uh, having an optometrist working alongside you handling LED treatments is definitely the better and more efficient model. And I think for me, it's been a game changer, especially looking at my situation where I split time between two locations. Having a optometrist who's in Sioux Falls 5 days a week dramatically improves scheduling flexibility. And if I'm only available 2 or 3 days a week, that would severely limit access to not only light treatments, but impact my ability to fill my schedule with evaluations, follow-ups, things like that. And I think this model allows us to, keep moving forward treatments, prevent a bottleneck, even when I'm in the OR or at a different location. I think it creates a smoother and better patient experience. And I think it's not just more efficient, it's scalable, more scalable than, the model I'm currently working in at one location.
And it does really take advantage of both providers, the optometrist and the surgeon, operating to the very tip top of their training, right? So
That's right.
you're hopefully staying in the OR. They're doing the most robust way to leverage a refraction for patients' benefit, and I think that definitely has we should look at that as we look at the future when we know there's doctor shortages and access issues and yet demand is increasing, right? I think models like this are going to
Mhm.
be important.
And I think if you just think about the alternative, if a surgeon was in the OR 2 days a week, that's 40% of the week where they might not be available to perform light treatments. And so suddenly you're trying to, fill in light treatments in 3 out of the 5 days of the week. And, I think integrating optometry into this process, you mitigate bottlenecks. You allow the surgeon, as you mentioned, to focus on what they do best, perform surgery, and allow the optometrist to, do what they do best, leading the clinic.
Well, and I think like other collaborative models, because it exists in other subspecialties in healthcare, right? There just has to be a very clear message to patients that, I'm going to be back in surgery. Your light treatments are going to be handled by this specialist over here. But if you ever need anything, I'm just raise your hand and I'll be right there. Right. I mean, I do think patients like knowing that they can still access you.
Mhm. Yeah, and I think this kind of comes down to how you communicate from the start.
Mm.
So I think you set the expectations clearly from the start. And, when I'm counseling a patient, I kind of talk about the LA process in phases, talk about, performing the surgery, and then there's a healing period depending on the patient. And then after the healing process is complete, we'll begin the adjustment process. And that occurs either with myself or Dr. Moore, who works closely with me on all LAL cases. And I think framing it this way and consistently reinforcing that we're a team, patients don't know any different and they're completely comfortable. And I haven't experienced any pushback to this model. And I think at the end of the day, patients just want great results. And as long as the care feels seamless, then they trust the process.
Yeah, I think that's right. All things being equal, if you were to, because I know you're early in your career, I think you've been outside of your fellowship are you at the end of your second year?
Almost, yeah. Good memory.
Yeah. And so, you're early in the process. If you had your way, would you have an optometrist helping you with light treatments in both locations?
Yes, very much so. And because, this cat is already out of the bag, I'm actually going to have an optometrist joining me in a couple months in Sioux City. So she'll be working there with me 2 days a week and then also working at our Sioux Falls location and, helping out with light treatments in clinic. And so it'll be
That's
great.
great. I mean, so it's a unique moment in time where you get to talk about the benefits of both models, and yet, if you had your preference, you would do it the way that you're setting up to do it now, which is
Hmm.
to be
Very much so.
heavily collaborative. That's good to know too for listeners who are thinking about how to build their program.
But I'm very, like I said before, having that experience of performing the adjustments myself has definitely deepened my appreciation for the adjustable lens tech or the, light adjustable lens, because I think what you lose out on when you aren't seeing some of these patients back for that process is, kind of that satisfaction. I think
Yeah.
sometimes we can take a jaded view towards advanced technology IOLs because oftentimes no news is good news. But when we start seeing back patients regularly, it's usually the patients who aren't as happy as we want them to be or aren't as happy as we think they should be. And I think that kind of gives us a jaded view of a technology when this having to get these perform these adjustments is, like I said before, deepen my appreciation for the lens.
Well, and you get to celebrate Christmas morning with them, right? Isn't
That's
that
right.
great?
That's right.
And
That's right.
I think that's the nice aha about this technology is that you get to enjoy that with them. Well, listen, Dr. Ferguson, I would love you to just, if you don't mind, just give kind of a closing statement on the difference between the two models and the benefits of both.
Sure. So first thing I'll say is that, you know, I think the most exciting aspect of the LAL is that it not only empowers patients with the ability to customize their vision, but it's also opened this door for new collaborative models of care like we've talked about today. And having worked both within both models, performing light adjustments myself in one location and then also partnering with an optometrist in another, I think I've seen firsthand that both can deliver great outcomes, especially when it's built on strong communication, shared goals, and a kind of a clear patient-centered approach. And I think at the end of it, or the heart of it, the success with LAL doesn't come down to who performs the treatment. It's about the consistency of the team behind it. And I think when expectations are aligned and roles are clearly defined, trust and satisfaction naturally will follow.
I think that's really powerful. It comes down to the team and chasing visual quality, right? Like you mentioned before. I want to
That's
ask you
right.
just a couple more questions that aren't necessarily tied to collaborative care, but I do think that you are well suited to answer. And that's just about how has the light adjustable lens been a practice builder for you?
Well, I think it comes back to what I was talking about earlier and how the light adjustable lens to me um, has a broader candidacy of patients who are motivated to reduce their dependency on glasses. And I think that's why it can be a practice builder. It can not only help build, but grow your refractive cataract practice. And that's because of the unique aspects of the technology and the quality of vision that it delivers. It's the only lens where I've had patients come back and tell me they enjoy driving at night. Like,
Hmm.
wow, I can't believe how well I see driving at night. And I think that speaks to the quality of vision that this lens delivers. Um, and then I think the obvious aspects, like I touched on before, the ability to kind of test drive their vision in between the adjustment process, overcome the limitations that exist with IOL power calculations. Um, I think those two aspects really set it apart.
Now, there's a lot in there, right? When you say test driving your vision and they actually enjoy the driving at night, there's a lot of double meaning there that's kind of fun. You also work pretty closely with area optometrists, right? And what kind of confidence has this given to doctors who, who refer patients to you or share in the care of those patients?
Yeah, I think we've been doing it long enough now to now those optometrists are comfortable talking to patients about it, that I'm starting to see patients who are referred for LAL. And I love when I get a referral sheet and it says LAL and it's circled and that's it. Like it's if a patient has it set in their mind, that's what they want. I actually had a patient who I hadn't seen yet for their evaluation who had was very set on the LAL. Their friend had the lens and loved it. And this guy, I called him before I saw him for evaluation. He's like, "That's exactly what I want. My friend has it, is over the moon happy." And he had actually scheduled his light treatments before I even saw him for an evaluation. And all I could think about was, hopefully this guy dilates. It's
Right.
because it's not going to be fun to tell him we can't do the light adjustable lens if he doesn't dilate well enough.
But he had a good experience.
He did great. He was one of those unicorns that saw super well at distance, but also achieved some good intermediate and near vision.
Yeah, that's fun. Congratulations. And it's fun to have people who respond well to a technology. By the way, just as an aside, just knowing what consumers love, that is the notable thing about this is people, they talk about it because it's
Hmm.
different enough to where they pay attention and they remember what their friends say.
Yeah. On
Well,
that
Dr.
same note,
Ferguson,
go ahead.
no, no, you,
Yeah, on that same note, I think people get excited about how unique this technology is. I think when you describe the process of you'll come back after you heal, we'll measure you like we're measuring you for a pair of glasses, and then we'll plug that prescription into what's called the light delivery device that delivers targeted UV light to change the shape of the lens inside your eye non-invasively. It's not more surgery, but here in the clinic. And I think when you describe that to them, there's a wow moment. And then I also like to arm people with additional information on the lens when they walk out to let them further read about it. And I'll say something like, because this lens technology is so unique, here's some additional information to read about before your surgery.
that's really great. Yeah, I think that word of mouth and that aha, it's kind of like we're finally able to give them what they've expected from us all along.
Yeah, that's right.
Well, I want to thank you for your time and the discussion that we've been having about the light adjustable lens, and thank you for joining us on RX Site Ed, where we talk about how to implement this technology at the point of care. Dr. Ferguson, you're a good friend. Congratulations on your success so far. We look forward to hearing more from you.
Thanks, Matt. Thanks for having me on.